Hello, my name is Dr. Russell Muir. I'm an assistant professor in the master's program in athletic training in the kinesiology department. And today I'm going to discuss some of my results from a research project called Clinical Decision Making in Athletic Training. Now, some objectives for this presentation is I want to first introduce the subjects of this study, certified athletic trainers. We'll get into detail of what that profession is and why it's relevant to this area of study. I'm going to explain heuristics and cognitive biases, and these are kind of the crux of what my research interests are, because these can be threats to decision-making efficacy. I'm going to detail a little bit of the research design that I used and some of the key findings, and answer the questions: are heuristics and cognitive biases taught in athletic training education? And what are their perceptions of their use by clinicians? So to begin, what are athletic trainers? And this is a question that we have to answer quite frequently. And the way we usually do this is by saying, hey, do you watch sports? Yeah, do you see when someone gets hurt? You see the people who run out there, the men and women who run out there to provide medical care and aid for those athletes. That's athletic training. Those are athletic trainers. And that's the traditional setting of athletic trainers, is dealing with competitive athletes in school, college, or the professionals. But the profession has really broadened its scope. Athletic trainers have entered things like the performing arts, things like tactical athletes for fire, for police, for military. They've entered the industrial setting, dealing with ergonomics and workplace injuries in places like warehouses, Amazon, FedEx, and those things. So very wide scope of athletic trainers. And here is just the kind of catch-all definition. Athletic training encompasses the prevention, examination, diagnosis, treatment, and rehabilitation of emergent, acute, and chronic injuries and medical conditions. And we're recognized as allied healthcare professionals by a number of different entities. The interesting thing about athletic training is we are really the healthcare profession that sees an injury or condition from prevention all the way through acute care, all the way through treatment, through rehabilitation, through returning to activities of daily living, but also returning to sport and competitive into competition. So we really are able to see the entire continuum of things like injuries. So why is that important? We want to look at this point, how athletic trainers make decisions, and more importantly, are we recognizing some of the threats to our decision-making efficacy? And so to start with this, we have what are called heuristics. And heuristics have been around for a long time, first really documented in the 1970s. And what these are just mental shortcuts. And if you think about how many decisions we make in a day, we make thousands of decisions, and so many of them are made without really a lot of cognitive effort, without a lot of cognitive attention on our part, right? What hand do I open the door with? What leg do I put my pants on first, right? These are all decisions that are made very quickly, but also we have this ability to save cognitive effort. Okay, and so when we are in situations of duress, right, we want to be able to think quick, to act fast, and oftentimes we will deploy these heuristics, and they're subconscious, right? So we don't necessarily know that we're doing them. These are powerful tools that could save time and mental effort. So in athletic training, we're often in emergency scenarios, right, where time might save a life. And so because of that, oftentimes we don't have the time to sit and hit a checklist of 32 things of what to do next, what to do next, what to do next. We have to think quick, and oftentimes we will use heuristics for that. Unfortunately, so this is a very powerful tool. They should be used. They are used to great effect. But research has shown that their use lead to cognitive errors called cognitive biases, right? And so they are indelibly linked. The use of heuristics and error is going to occur. And research has shown that that these heuristics and cognitive biases are linked to diagnostic error and suboptimal treatment decisions, right? And so that's why I wanted to look at this, because athletic trainers' reach is so broad. We're healthcare professionals. We want to make sure that we're arming new students with the ability to make proper decisions. And so this is a list of some common heuristics and cognitive biases associated with the clinical decision-making. So these top 3 heuristics, these were from the 1970s, and they still hold true today. So think about it in terms of the last time you went to the doctor's office, right? So we have anchoring, which means the clinician will have an over-reliance on the first piece of information that was given, right? And so we understand, and it's been proven, that the things that you say at the beginning and at the end of a sequence are remembered better. But with anchoring, you take that first impression and you latch onto it, right? You've anchored yourself to that first piece of information that leads you, that just anchors you to what you think it is. Availability, on the other hand, is a tendency to overestimate the frequency of an event or scenario simply because it comes to mind more easily. So this is where, hey, that idea, that answer came quickly to my mind, so it must be correct, right? So this is, if it comes to mind quickly, that's the one that you're going to go with. The next one is called representativeness. And this is assessing the likelihood that an object or event belongs in a specific class or process. So we see this all the time. If it looks like this, then it must be this, right? This is, if it looks like a duck, walks like a duck, quacks like a duck, it must be a duck. And representativeness can be really important to a medical clinician because we see cases all the time, right? And we say, hey, this presents just like this case that I had, last week, or I see all the time, and they represent each other. The problem with that is if you make that determination too soon, you may have missed some things. So you may not be able to put it into that box, right, of that stereotypical archetypal presentation of a condition. And we have some cognitive biases out there. There are hundreds of cognitive biases when you look at decision-making research. Some of them are more linked to the medical world than others, but this is, and who really has pushed a lot of this is marketing and advertising, right? There's a reason, there's multi-billion-dollar industries trying to get you to buy product A instead of product B. And they're using these biases to their advantage for them to sell things. Things like the bandwagon effect, right? So everybody else is doing it. Now, how does this make its way into the medical world is if there's a brand new treatment coming out, right? Or if you see somebody else using something, then I must do it too. Why? Because everybody else is doing it. I have to stay up. I have to stay up to date, right? Regardless of what research says. Confirmation bias. This is a tendency to seek and overvalue information and evidence in support of our own belief. Now, this becomes very dangerous if we start linking these things together. Like if we have anchoring heuristic with confirmation bias, that means we prematurely came to a conclusion based on the things that were presented early in the presentation. And we're and everything we do subsequent to that, we just confirm what we think in the beginning. Okay? And it creates bias. We also have what's called the framing effect, which is how things are framed, strongly influences the clinician's decision-making process. So if we're positive, if we're negative with how events are framed, it can bias our decisions. And overconfidence, a tendency where clinicians overestimate their skills. So if you combine things like confirmation bias with overconfidence, with anchoring, you can see how this takes us down a poor road, because we're anchoring to that one bit of information. We're getting there too soon, but we're so confident in ourselves and our abilities that we're not going to kind of second guess that and come off of that anchor. So you could see how in the medical world, this becomes important to identify so that we can have better diagnosis and we can make treatments that are most optimal to our patients. So what is the research design here? I developed a questionnaire to assess some demographics, some experience. I wanted to see if experience had a difference in heuristics, to see if it was taught and when it was taught. Our curricular pathways have changed over the last 20 years for athletic training. We are now an entry-level graduate program. where it used to be an entry-level bachelor's degree. And so our accreditation has changed over time. So I wanted to see if there was any differences there. There were not, unfortunately. And I wanted to see if people were taught about heuristics, if athletic trainers were taught about heuristics and cognitive biases, and to see if they, had some perceptions as to how they're used. So I used a Likert scale of responses and electronically distributed them to certified athletic trainers. So some results. The survey that I created had some good internal consistency with the Cronbach's alpha there. 112 participants completed the survey. And the key finding here is that very few, 11.6%, were taught about heuristics, but 24% were taught about cognitive bias. Now I'm going to get to some of these results too, of why I think there's a difference here, because those who are taught about heuristics, it's very difficult to teach heuristics without their associated error of cognitive bias. So the main results here, those who indicated being taught about cognitive bias had statistically significantly higher agreement with being able to define cognitive bias and report the ability to describe how cognitive bias influences their decisions. And that makes sense, right? If you were taught it, you should be able to describe it. The next key finding here is that those who indicated being taught about heuristics had statistically significant agreement with the ability to define both heuristics and cognitive bias and reported the ability to describe their use. So this makes sense, right? Because if you teach heuristics, you have to teach that associated cognitive bias. But why is there a difference here? Why do more people know about cognitive bias than know about heuristics? And my guess is that bias gets put into a basket. And right now, we talk quite a bit about implicit bias and stereotypes and all of these diversity, equity, inclusion topics related to bias. So my guess here is that respondents saw bias and couldn't differentiate what kind of bias that was. And so they might say cognitive bias, and they might mistakenly associate that with implicit bias. And that might be the difference of why we see that there. But again, more to show that these topics should be taught because there is some misrepresentation out there. So interestingly, those indicating that they were taught about heuristics consciously avoided using heuristics in clinical decision-making. And so this is a finding that we would expect to be opposite, right? So as I mentioned earlier in this presentation, heuristics are a very powerful tool that we really should be leveraging, especially in times of uncertainty, time stress, stressful situations. And so if clinicians who know about heuristics are avoiding them, then we may be discarding unnecessarily a tool that might help us become better decision makers. And so these were kind of the key findings for this research. Now here is a very big and loud data table here, and showing the Likert statements here on the left. I used a Welch's analysis of variance here to look at significant relationships between groups here. So you could see that these columns are grouped. So I split this data in whether you were taught cognitive bias group or whether you were taught heuristics group, and then compared them. There was also an unknown group as well, or a group of I don't knows, basically. And so you could see here the taught cognitive bias group really only had significance in being able to define and describe how they're used. But here's our heuristics group who understands cognitive bias and who can describe and define heuristics being used. But also here is our odd finding that we would expect to be inverse of this, saying I consciously avoid using heuristics. So we would expect that to be a differing value there. When we looked at it post hoc, they were more consciously avoiding that use. So why is this relevant? Really, what are the implications here? And I think this research really shows that there's a deficiency in athletic training education right now. So as a goal, we're producing athletic trainers who are healthcare clinicians, right? And so, like I said before, we have a very broad scope in terms of setting. We also have a very broad scope in terms of the curriculum, or I'm sorry, the continuum of medical conditions. And so, because we diagnose injuries and because we treat injuries and illnesses and conditions, we really need to incorporate heuristics and cognitive bias into our educational program, into our educational programming. The recommendations are that we allow for continuing education opportunities to teach these topics to clinicians who have already become certified and graduated from school. And this way we can help to reduce diagnostic error and suboptimal treatment decisions. Now, you can look at this. There are some other implications socially as well. As I mentioned earlier, oftentimes athletic trainers are a key healthcare point for communities. And in our traditional settings of athletics, we know that athletics has a higher distribution of underrepresented populations. And so if we can improve treatment to our athletes, we can improve treatment to these underrepresented populations. Since oftentimes athletic trainers serve as kind of a gatekeeper to healthcare, or just an access point to be able to ask questions, to seek some medical care. So there are some wider implications here. That is the next iteration of my research here, is really tying, we'll tie this decision-making process, but also tie it to the athletic trainer as an access point for communities through athletes, right? And we know that obviously we know that there's some socioeconomics involved with that, right? So we can have a greater reach, and future research coming up next year through this fellowship is going to link that to social determinants of health as well. So this is the foundation of, do we need to teach it? Yes, we do, but now we need to actualize it into communities to have an effect. So that is the research, my research presentation for clinical decision-making in athletic training. I hope it was informative and useful, and I can be reached if anyone has any questions or comments, concerns, or any other research avenues that should be considered here. So thank you very much.